talking about ADME, refreshing ourselves on ADME because we already talked about it before. And so what we're going to look at is how do I go about making sure that my medication is getting to the site that I want it to go to. I need my medication to go into my body to do something, right? That's why I'm giving them medication, whether it's for pain, blood pressure, cholesterol, like there's so many different reasons why we're giving a medication. If I can't get through this ADME process, it doesn't matter that I'm giving them these meds. So there's several different things that we take into consideration, and there are going to be several different things that can affect ADME that you need to take into account whenever you're giving some of your meds. So when we're looking at your absorption, it's essentially what it's saying, right? Like, can I get my medication into my body? Can my body absorb this? Whether it's orally, whether that is me putting on a patch and it's topically, or a cream that I'm putting on topically. Make sure that you're understanding those basic principles that we talked about before. So when you're looking at all of this, this is essentially what you already went over in biochem, but just understanding that we're trying to get that drug absorbed so that we can then transport it to where we want it to perform its action, okay? So a lot of these words and like the liquid partition coefficient, I'm not gonna ask y'all things like that. Like I might be like, okay, what is absorption? Or we're not gonna get into it in the biochem like depth of it, okay? Plus you've seen these already. All right, so first pass, this is a big deal for medicine and us talking about medication. And we talked about this yesterday about how depending on my route, right, or the extent of my first pass metabolism, I may have a different route that I want to take. You're likely to see this, more likely to see this in your medications that are given orally, because they're going to go through that first pass a lot more than something that I'm going to give IV. And that's what I was telling you when we're talking about our IV. We kind of say like, all right, not all of our, I guess I'll say it this way, not all of your intro routes undergo first pass. So for instance, like orally we take, we can have like a sublingual or a buccal tablet that they're going to use. And those don't undergo first pass the same way as if I were to swallow like a tablet, okay? So those are going to be to a lesser extent of experiencing first pass. So I don't want to say, that's why you see predominantly applies to orally administered. Not every single thing that goes in someone's mouth is like going through first pass, okay? So those two are kind of like the exceptions that you'll see to that. And then the big deal with first pass is like now I've gone through this and I've lost, right, some of the effect that my drug can actually do at the site that I needed to go to. So therefore my efficacy, my effectiveness will be decreased if I'm undergoing extensive first pass metabolism because I don't have enough drug at that site that I need there to produce the action that I wanted to produce, okay? So that's the big idea that I want you to remember here. Also, when you talk about rectal medications can undergo first pass as well. It varies, but those can also undergo first pass. So we think that we're missing it, but depending on how it is absorbed, some of it does go through first pass metabolism also. Okay, so when you're looking at this, a good example is lidocaine. How many people have had lidocaine patches? Seen lidocaine patches, right? Big patch, you cut it and put it on your different sites. And the reason why we see that we have it as a patch and not as oral is because of the amount of first pass that it goes through, right? So if I'm going through that extensive first pass metabolism, then I'm not going to get the effect that I want to get. So what they did when they made the drug is they said, hey, let's put it in a patch. If I put it in a patch over the site that I needed to go to, it's going to get absorbed right there and it's going to work right there. Okay, I'm bypassing that first pass metabolism. I don't have to worry about it, and now my drug gets to where I need it to go. Okay, so that's what I was talking to you about yesterday. Is like this can affect the how we make our drugs, right? Once we're doing that phase 1 part of things, phase 2 of like, okay, is this gonna work? Is this actually getting what I needed to? Is it actually doing what I need this to do? Okay, now maybe I can change the formulation. Maybe I can do something else so that it does do what I need it to do. And then ways to obtain better absorption, all those are listed here, right? So increasing the dose. Have to be careful with this. And I talked to you about resources yesterday, like your LexiDrug or your LexiComp. Make sure that you're not exceeding that maximum dose that someone is allowed to have, right? You can't just infinitely increase doses. There's going to be a side effect. All of our drugs have side effects. Some of them are more serious than others, but all drugs have side effects. So make sure that you're thinking about, and you're still within that normal therapeutic range and a safe therapeutic range. Also that different route. So that's what we were just talking about with the lidocaine. And then modifying the release of the drug. So remember when we were going over the different abbreviations and we were talking about control release, sustained release, long acting, and how sometimes that can also, outside of decreasing side effects that a patient experiences, you can see that that can help with the absorption as well in the GI tract. So these are like kind of ways that we will manipulate the drug that we're giving that patient to get the desired effect that we want, okay? All due to one little thing, first pass, right? First pass affects a lot when we're talking about drugs. I do not need you to remember these numbers, these values, okay? What I want you to think about is the principle. When you're looking at your route, okay, and just think about it, you look at our IV, we talked about bioavailability, and I told you that even though it may not actually be 100, it's super close to 100, and we always say that F is gonna be 1 or 100% for our IV meds. So if you're ever looking at a chart, and you see it all starting all the way at the top, or at 100, that means that was given IV versus the ones that we've been seeing so far where they were at the bottom and then you see them starting to peak up. That's letting you know that it's going through that absorption phase versus my one at the top, my IV, it's already absorbed because I put it exactly where I needed it to go in my bloodstream, okay? So your IV, you see that your bioavailability is 1 or 100%. And so if I'm absorbed like this, I can work like this, right? So that's why you see that it has that rapid onset. So I do want you to know that like your IV is usually your quickest option that you have, and the one where you're gonna get almost all of your bang for your buck. All that drug is going likely to where you need to go, okay? And then as you go through, you have your IM, sub-Q, sublingual, and that one is the one that's under the tongue, your oral, your rectal, inhalation, transdermal. You see with this oral, we have a huge range, right? 5 to 100%. That is super variable. A lot of the times when you see the ones that are on the lower end, like that 5, 10%, we have some other type of formulation that we're gonna use so that we can get more of our drug to the body and they're not just taking a pill to get like 5 or 10%. Some stuff we're fine with the fact that it has poor oral bioavailability because we need it to work at that site. So one drug that I can kind of think about would be like vancomycin. So if you take it, we'll get there, I don't want to confuse y'all. We're gonna talk about that next block. But there's some drugs where we don't want them to be absorbed so they can work in a certain area, okay? So we'll say, all right, yeah, now this one, take it orally, okay? And then we'll get a certain effect that way. Your transdermal, lots of things that we need to take into account. Is the skin broken in that area? Are they older? Are they a baby, right? Because we have more fragile skin when we first come into this world and when we're older and we're about to leave out of it, okay? What do they say? Once a child, twice, or once an adult, twice a baby or something, once a child, twice a baby. So like, remember, those are your two populations where if you're putting anything on the skin, whether it's a patch or it's a cream, that matters, okay? Because now that absorption can increase and that dose is now higher than what you typically would think it is in an elderly patient or a child than like a normal adult, okay? So with this, all I want you to know, pay attention to your IV route, understand that your oral is very variable, but it is the easiest route that we have, the least invasive, or one of the least invasive routes that we have. And so a lot of people like it, but we're worried about our first pass effect, okay? Yes?
Does IO, is that 100% as well?
Yeah, most of the time, yes, because you're going right into your bone, but yeah. That's a good one. Y'all would use that a lot. Now you're giving me other things to add. Y'all give me a lot of homework. Y'all making me work. Okay, so your plasma protein binding. Binding is something that, again, will affect how much of your drug is getting to where we want it to go. Y'all have talked about this as well. So the way that I like to kind of think about this is that if something is bound, it's not active. If I am in a relationship, I should not be on a dating site, right? I'm bound, I am not active on Tinder, okay? I'm trying to help you remember, right? So I am bound, we're not active. Deactivate your profile, okay? You can't do anything. If you are not free and floating, you can't do anything, right? Only my free drug is active. Only my free drug is able to say, I'm gonna bind with this receptor, okay? But if I am bound, I'm in my relationship, I'm not free. I can't do anything, there's no activity, okay? You may get a date every now and then when you're bound. So, remember that, okay? Remember. Now, binding can change if someone is pregnant. You'll see that sometimes bounding gets affected in those populations, and so you'll have to dose adjust when you see some of those patients as well. So pay attention to those patients that you are diagnosing or that you're telling them that, notifying them that they're pregnant. Because again, some medications that they're on, until they get to that OB appointment, those doses may need to be changed. Just go and look them up and try to see when they have their appointment with OB, so that you can hold them over until that point. You may not have to do anything at all, but you may have to, because some drugs are not affected by this at all. So when you're looking at a drug that has high protein binding, that's when you're worried, okay? Because now I can have more displacement. If I give it with another drug that also has high protein binding, now they're competing with each other, right? So now it's kind of like, who's getting there first? Okay, so that's what we're worried about when we're looking at that. And then drugs with a narrow therapeutic index, we're worried about those too, because now a small shift in what may be bound or not bound can cause that drug to now be above that therapeutic range. It could put me in toxicity because now I'm not as bound. I'm free. I'm out here and I'm doing damage, okay? Like, that's what is happening whenever we talk about a narrow therapeutic index, okay? So we are really, really worried. We're on high alert when you see anything that says narrow therapeutic index, because we don't want to get above that therapeutic, that maximum therapeutic window. Yes?
So if you have less plasma binding protein available, so you can run into the issues of toxicity, right?
If you have less binding available, yes. Because now you have more, yes, more free. So now I'm out and I can bind to the receptors on those target tissues, and now I'm affecting things, okay? So just, again, make sure that we are remembering bound is not gonna do anything. They're not active, okay? And then this is looking at kind of what we were talking about when we were saying the phenytoin, which had the narrow therapeutic window, right? So our ideal concentration that you would want to see would be between 10 to 20. And then as you have that bound drug is now decreasing, you see your unbound increase. And so now I have more of it that could potentially perform an action. But I also now see that I have more, my level is gonna go up, right? And if that level goes up, that means that I could be outside of my window that I should be in. And then that's where you start to see the toxicity. Yes.
What causes something to unbind?
So it could be another drug. So like, remember how I gave you that example? So if I have two drugs that are highly protein bound, now they're competing for the same proteins, right? And so now we're competing. Who gets there first? One of them is gonna get left out, because that receptor can only bind to one thing at a time. So that's one. Sometimes, like I was saying with pregnancy, like certain health conditions, those can cause drugs to become unbound. Or you can have it to where it increases binding, and therefore you're gonna have less therapeutic effect than what you thought you had, because now you have less free drug because more of it is bound. So it can go either way. If I'm asking you, it could be in the sense of like, okay, if I gave you some, I'll give you the scenario and I'll tell you what's happening. I would say like, hey, your protein level has gone up, or your binding has increased, what's happening here, right? And then you're gonna tell me, or your binding has decreased, what's happening here. Okay, so just the basic idea of the relationship of being bound versus unbound, yes.
Is this more based on drug to drug, or is it person to person? Like, does a certain person have more binding, or is it more like different drugs have more binding?
So specifically looking at this, you're gonna draw a level for each person, right? Because I could have different binding capacity than you. I could also be pregnant and you're not, right? So that could affect it as well. So it just, when you look at a lot of those narrow therapeutic drugs, you're gonna pull lab levels for them, and they're gonna change every day. So it just depends on what's there. But if I have another drug that can also vary every day, right? Because who got there first? Who has a higher affinity for that receptor? Because one usually has a higher affinity than the other. So if I have a higher affinity, I might get there first. Or if it's competitive, I could bump you off and be like, I'm taking the seat, right? So there's several different factors that can control this, which is why when I'm talking to you guys and asking you about it, I want you to know, am I in a relationship or am I not in a relationship? Okay, what's happening? Because there's too many factors that I'm not gonna make you remember. All right, distribution. We know that this is oral now, right? Because of what we talked about. We see that it's having to go through that absorption to get to that peak before it starts to go through that metabolism and elimination, being distributed to the body to go through that metabolism and that elimination, okay? So when we look at our compartment models, we don't really deal with this a whole bunch when we're talking about like our medications. Like it's not something that we take into consideration like as far as like when we're prescribing. Because you already have everything kind of laid out for you. In biochem, I know y'all talked about this because this is a bigger deal whenever you're looking at a lot of that. So when you think about your one compartment versus your two compartment, think about your one compartment as being like your body is just one giant bucket. So that's what you see on that top picture there. So the drug enters that body and it's going to reach that central compartment, and then the drug recirculation doesn't necessarily occur. Whereas when you're looking at your two compartment model, you see where it's entering that central compartment. I don't have my little laser, it's not coming up. But it enters the central compartment and then it's gonna go ahead and leave through one of those two paths, right? It's gonna go through the peripheral compartment, which is compartment 2, is what they call it. Or it's gonna go through elimination and leave the body, right? Because like now I don't need it. I'm done, I use it for whatever I need to do. But when we're talking about this in that central compartment, it can, or leaving, and the way that it leaves, it can be recirculated now, right? So now it can go back into the body versus when I had my one compartment, it couldn't. It was gonna go in and it's gonna go out. Whereas when I have my two compartment, I can have that recirculation occur. So just remember, like when we're looking at one compartment, it's just looking at one thing. Whereas when we're looking at our two compartment, anything that's highly perfused, heart, lungs, all those things, they're considering that as a compartment and then the body as a separate compartment. So that's how we end up with our two compartment models. I just want you to know the basic idea with that. And then understanding with our one compartment model, I'm not gonna get into that because I'm not gonna ask you that way. That's all I want you to know. One is like one big bucket. Two, my highly perfused things, like literally just look at this picture, okay? I keep pointing like I have my laser, I don't. All right, so this is essentially what I was just telling you about, right? Your central compartment, all those things that are highly perfused, right? So your heart, your liver, your kidney, your plasma, like these are your big means of these are your bigger, larger, more important things that you have that are in your body that are then going to transport your medications to all of these peripheral compartments that you have, okay? So it's gonna pour into the peripheral compartments, okay? And then this is just showing you again with distribution how we took our drug, it's gonna get absorbed, right? So I've absorbed my drug and then it's gonna get distributed into my plasma, and then my plasma distributes it to all of these different target sites, wherever they may be, okay? And then we'll go to those receptors, they're gonna bind, and then they're gonna do an action. So distribution is essentially, I'm just trying to get you where you need to go. I'm gonna drop you off, okay? Absorption handed you off to me. Now it's my responsibility to get you to where you need to go. It's the school bus, okay? Volume of distribution. When we're looking at volume of distribution, again, this is another thing that lots of things affect volume of distribution. I'm not gonna make you remember this equation, so don't worry about that equation there. But what I want you to think about when you're looking at volume of distribution is just the measure of extent of the distribution of a drug within the body, right? So like how much of that drug got to where I needed to go. And then remembering the relationship with anything that has a high VD means that it has a high probability that it is gonna leave the plasma and go to that site that I dropped it off at. Okay, it's gonna get absorbed at that site. High VD, I'm very open to receiving that med, right? So it distributed to that tissue that it was going to fantastically. Whereas if you have a low VD, that means that it's not gonna be absorbed well into the tissue and it's likely gonna be eliminated in higher volumes than something that has a higher VD. Okay, so higher VD, more of it is getting to the site, a lower VD, less of it is getting to the site and it's staying in the plasma. Okay, so it's gonna be circulating. Don't remember the this calculation down here. This is just showing you different examples of kind of what's happening. So remember we said higher VD are more likely to get absorbed, so I'm more soluble, and that's all this is essentially saying. Okay, I don't need you to remember any of these values. I don't need you to remember any of this. Just go back to this side, look at the principles that we just talked about. This is just an illustration of that, okay? Don't remember values from this. You don't need to know that. Okay, you can look this up. All right, so we talked about these two things. We talked about volume of distribution, and we talked about the protein, the protein binding, right? So now when we're looking at them together, if I have a drug that has a high affinity for that protein binding, right, I now have a reduced VD because I'm bound to the protein. Now I can't distribute it in my tissue. I've committed myself somewhere else. So now I'm not free, right, because now I'm bound to this protein over here. Okay, so think about the relationship, right? And then how, now if I'm here, I can't also be, bless you, that was the thing. I can't also be available now to do my action because I've gotten into a relationship. Yes.
So I know you said to not get rushed around the actual numbers from that last diagram, but so looking at amitriptyline, it has a 95% plasma protein binding percentage, but it's also highly lipophilic.
That's why I don't like it. Because they're so here's the thing with these, right? Several factors go into play. So if I'm looking at this and I'm saying, all right, am I able to transition from going into these different departments? Sure. My relationship is not stable, right? So looking at this, sometimes one, not black and white. You know how I told y'all you picked a great profession? And so I try not to confuse y'all because to me this is going to be confusing to try to explain that. So that's why I said don't worry about the values, don't look at any of this, remember this. Remember the principle because that fits the majority. There is most of the time going to be an exception to the rule. Okay? So that is, don't,
That's easy.
yes. A unicorn. I'm gonna wear my unicorn headband tomorrow. All right, so we were on this one, right? Yes. So remember, essentially the same idea of what we were just talking about, the relationship, right? So if it's bound, it's not free to work, right? So if there's more protein binding, we have less of that therapeutic effect. When we're looking at albumin is a big thing that you start to worry about. We'll hear about albumin in different disease states as well, and you'll start to see that it's going to be excreted in the urine or eliminated in the urine. We'll start talking about that. But albumin is a big protein that we talk about in the plasma that a lot of drugs bind to. And this fluctuates also a lot in pregnancy because of those albumin levels and sex hormone levels. And so that's why you see a lot of the differentiation in the volume of distribution and the level of protein binding that happens in some of our patients, okay? So we'll see these and kind of see this idea come up again with some of our drugs, especially when we get into that psych department of the binding and what's free and what's not free with our protein binding. Blood-brain barrier. This is our protector, all right? The blood-brain barrier is essentially trying to keep things out that don't need to be there, protecting us from bacteria, trying to at least, right? So like all of the different things that can be very harmful to us, that's why we have such a like tight-knit blood-brain barrier. So it's gonna say, hey, you're allowed to come in, you're not. The blood-brain barrier is the bouncer, okay? It's like, no, you can't get in, all right? Now, when we look at this, we think about the solubility again. It'll keep coming into play. So if I'm lipid soluble, if I have high lipophilicity, then I am likely to be able to cross that blood-brain barrier. It likes me. I can go. If we're talking about lipophilic, is that charged or uncharged? Uncharged, right? I have no baggage. You let me in. I can go in. I love it. Okay? So uncharged. Remember that slide that we talked about in the very beginning? Go over that because those words can come in any type of way, right? Lipophilicity, uncharged, you can say that anyway. So just remember to review that every day. Just look at it so you can remember. All right. How long have I been going? 25 minutes. Okay. Metabolism. We're going to go over this and looking at our metabolism. Y'all seem to be doing just fine with this, so I'm not going to spend too much time. But here, just understanding that this is where we're trying to say, all right, what are we going to do with this drug? We're going to deactivate it? Are we going to activate it? Like, how are we going to go about this drug? I'm not really concerned about you looking at phase 1 or phase 2 because y'all have already done that. But just remember that you have those 2 phases. Because because you take a drug, it doesn't mean that it has to go to phase 1 before going to phase 2. A drug can also automatically go into phase 2. Okay? So you don't have to have this like in order. I take a drug, it went to phase 1 and then phase 2. I can take a drug and I can go automatically to phase 2 as well. Okay? So big idea here, just understand you have 2 phases and we're metabolizing our drugs. What I want you to focus on is we're going to get to that, and that's where we're going to start looking at this. Again, just skimming over this. Remember, this is your non-synthetic reactions that you have, and that's just involving the breakdown of that drug, a breakdown of that compound once you took it, okay? So it's getting it ready for us to be able to absorb and distribute that out to the body, right? So like I got it, I distribute it, I get it, I'm trying to metabolize it to make it digestible for my target so it can go do its action, okay? So that's what our phase 1 is essentially doing. And then your phase 2, this is just like those synthetic molecules that are gonna sometimes form new molecules, more complex molecules, and then it also will help you be able to, or help the body be able to excrete that drug, okay? Because it's making it more soluble. So remember, if something is more soluble, I'm likely to go ahead and excrete that, getting rid of it. I don't need it anymore. Okay, so those are just like skimming over those, not really worried about that. This is where I start to get worried. Okay, so we answered this correctly when we were talking about the different types of metabolites that we have when we did our pretest. So I have my inactive, my metabolites that are going to retain similar activity, some that will have more activity, and then your bioactive metabolites are what we usually refer to as a prodrug, right? So I'm going to be taken, and then I need to go through metabolism in order to have some activity in the body. If I don't get metabolized, I'm not doing anything. I have to get metabolized once I get inside, okay? So think about like a prodrug sometimes. I think about it as like a Trojan horse, right? The drug is getting me in there, and then I have to get something to let me bust out, bless you, so that I can start doing my attack. I need to work, okay? So your prodrug is not active until you get it metabolized on the inside, okay? The reason why we do this is because we have better absorption. So one of the examples that we have up here is valacyclovir. It's not the only prodrug, there's several. And so you'll use this for like cold sores, herpes, things like that. When you look at valacyclovir, in most prodrugs, you can take them less often than you would the actual drug, right? Because now it's going to be in my body for a little bit longer because it's going to be going through metabolism, and then I'll be slowly getting new active drug coming out. So a lot of times, if you have something that is a prodrug, usually you can take it like once or twice a day. Versus if you were looking at the actual drug, so like acyclovir, sometimes I could take that 3-4 times a day. Some of them you'll see different versions where they're like 6 times a day. So it just depends on what's going on with these prodrugs, okay? So valacyclovir will be metabolized to acyclovir, which is also another drug that you can use for infections like that, like herpes and stuff, okay? So, we like prodrugs because they help us with our delivery, absorption, your PK is better, decreases toxicity, like there's lots of benefits from us having our prodrugs. All right. I need you guys to remember every sip that we have, okay? Because I'm gonna ask you about it. I'm just joking. I am not a serious person. You're gonna look up sips because there's lots of sips, okay? I don't remember all the sips, okay? I'm just joking with y'all. Y'all are so quiet and like straight face. I'm trying to make y'all laugh, but it's just not working, okay? So, when you look at, I know y'all are terrified, but pharmacy is really not that bad. We're gonna do great. We got this. We're gonna do good. Okay, when you're thinking about a sip, or anytime you see a sip, first thing that should pop into your head is, I need to see if this has interaction. Okay? This is a big part of metabolism, and if you have someone who is taking multiple drugs, and they all need to go through the same sip, you're gonna start to have issues, right? We're clashing, because now who's getting there first? You need to wait your turn, so now this drug isn't gonna work if I'm over here. Or I have some drugs where this one might be an inducer, meaning it might speed some stuff up, right? So now I've spun up the activity of my drugs, depending on if it's a prodrug or not. Like now I've caused a different response than what I was expecting to see, okay? So when anytime you see anything that's talking about a sip, or you see a sip introduced into any type of equation, you're thinking interactions. Like what interactions are there? What drug is affected by this sip versus that sip? And then you'll have some drugs where they're metabolized by several different sips. Okay, so it's not like one drug is only to one sip. I could have one drug that has 5 different sips that it's going to be metabolized by. Okay, so just keep that in mind whenever you're looking at this. And your big idea here is interactions. Some of our drugs are going to have more sip interactions than others. Okay, when you see them, you're going to be like phenytoin, right? You want me to remember all of that? You want me to remember 3A4, 2C19? No, I just want you to know there's a lot of interaction. Okay? All right, so I use some terms. I know you're kind of familiar with them, but want to revisit them. So you have a substrate, and that's what the enzyme is going to act on, or like in this situation what we were talking about, the drug, right? So that's your substrate. And then you have what could be induction or inhibition. Induction is like you're speeding something up, is a simple way to put it, right? So if I'm an inducer, I'm gonna speed up the metabolism of that. So think about a kid who you just gave candy to. Your candy is your inducer, and now that kid is like they're going a lot faster. Versus inhibition, which is gonna slow down metabolism. Think about, unless they have a paradoxical effect, think about giving a kid like Benadryl or melatonin, right? You're expecting for them to kind of go down their metabolism. Sometimes that thing don't work, okay? But that's what you expect to happen. In kids, seriously, with Benadryl, sometimes it can make them more hyper. And so you would think that they're going to sleep, and they don't. They have the opposite reaction. I haven't tested the theory yet. So inhibition, induction, your substrate is that drug, okay? Now, when we're looking at this, just make sure that you're understanding, again, interactions is what we're trying to remember. So a source of a lot of interactions. And that's all that this is saying, the same things that we already talked about. I just want you to remember lots of interactions. Your substrate could also be an inhibitor, right? So my drug could also inhibit that sip. It's not necessarily that sip has to always be the thing that inhibits or induces the drug. The drug can also do those things to the sip, okay? All right, this is a very important slide for you to remember, okay? So, if I have a drug, let's see if our mouse wants to work now. Okay, I have a drug. My drug is also called a what? Substrate. So I have my drug, I have distributed it to where I need it to go, and now I need it to be metabolized, okay? I have a sip here. when it goes through that sip, we're gonna be very basic, I got an inactive metabolite. That was the result, okay? So, bless you, what's gonna happen here is this will eventually leave my body, right? It's gonna be eliminated. Now, if I introduce an inhibitor or an inducer, my effects are now going to change. Remember, this is just a regular drug, it's not a prodrug, okay? So this is just your typical drug. If I put an inhibitor, I am going to expect to see my metabolism go down. This was my Benadryl, this was my melatonin. I'm slowing things down. So, if I slow down the metabolism of this drug, now I have more drug hanging out in my body. Okay? So therefore, I'm likely to see more side effects. I'm likely to see more toxicity because I'm not making it to my inactive metabolite product to get eliminated. Right? I'm just hanging out. You slow things down, cool, I'm gonna hang out here longer. Now, if I'm taking several doses of something, now I have to worry about accumulation, right? And that's how you start to see these side effects increase. That's how you see the possibility of having toxicity because more drug is just floating around like, I guess I gotta wait my turn until I get metabolized and then I'll get eliminated, okay? If I have an inducer, this was my candy, right? So, have my drug going through, I have an inducer. Boom. Now, I have more of my drug being metabolized to an inactive metabolite. Okay? It's like a quicker turnover. Now more of that drug is going through this sip. So therefore you have an increased risk of your medication not working. Because there's not enough drug left around to do the action. There's not enough drug floating around anymore. I'm eliminating it too quickly. Okay? Our body is expecting for this to be exactly how we did it in the study, right? So my dosing is based on a perfect scenario. But if I have an inhibitor or an inducer, I now have to change things. Typically, if I have an inducer, I might have to dose it more frequently now. Because I have to introduce drug back into my body quicker so that I don't fall below that therapeutic range because that's what's happening. That's why you have the therapeutic failure because you're eliminating more of it quicker. So sometimes I might say, okay, well, you're taking it every 12 hours and you're on an inducer that we can't take you off of right now. So instead of taking it every 12 hours, you're gonna take it every 8 hours, okay? So that's how you look at this. Everybody clear on this? I got all, okay. So now, when we're looking at our prodrug, this is different, right? This one, we said that we had to go through metabolism to become active, right? So here, I'm not doing anything until I get through my metabolism to become active, all right? So if I have an inducer, this is an inducer, I have an increased rate in which I'm producing active metabolites. I turn it up. Therefore, now you're seeing the increased risk of side effects. You're seeing more of your active drug being available. Okay, so it's like the opposite. And then if I have an inhibitor, I have a decreased risk or a decreased activation of that drug. So now I have a bunch of drugs that has no activity, that's just hanging around in my body. Now I have the increased risk of therapeutic failure because there's nothing active. I'm not activating it. Bless you. Okay? So keep this in your brain. You may or may not see it again. All right. More on metabolism, looking at our kinetics, your first order versus your zero order. We see this and we talk about it. It's just not something that's super pronounced. What I want to do is just tell you this. When you're looking at your zero order kinetics, just think about it as they're undergoing like constant elimination regardless of that plasma concentration. So regardless of how much you're throwing in, it's having constant elimination no matter what. When you're looking at your first order kinetics, this becomes a little bit more tricky. This one is saying, all right, the higher amount of drug that you put in, the higher elimination rate. And sometimes this can be proportional, but sometimes it cannot be proportional. And so that's why that becomes tricky when you're looking at your first order. So when we look at some of this, we don't talk about it a lot with our meds. I don't think I'll touch on this ever again whenever I'm teaching you, to be honest with you. So just kind of skim over this and understand that like these are ways that your systems can become saturated and you can have a greater response than what you were intended to have with your medication, okay? Based on if it's doing first order or zero order kinetics. This is so annoying, I cannot keep sniffing it out here. I'm sorry, hold on. So when we're looking at the things that can alter metabolism, right? So like, what can I do that would affect the rate at which something is metabolized? Some of this would be things that occur over time as we get older, right? So the older you are, you'll start to see body changes. And when your patients come in, you're gonna see things that are changing, and they may be symptomatic, they may not be symptomatic. So I'm gonna go in order whenever we're looking at this. So your genetic variability. Some races have different types of genotypes that are gonna be common a lot in that race. When we're looking at things like, we're gonna talk about this, but HLA-B 1502, which is in some Asian ethnicities, you will see that they're more likely to get SJS or Stevens-Johnson syndrome whenever they're taking certain medications. There's certain genes that are in African Americans where you're more likely to see them and therefore they're more likely to have certain reactions. So this is just telling you like some alleles that we have can affect how our medications are metabolized, and it can cause sometimes very harmful side effects, okay? Different diseases that you can have. So if you think about like liver disease, kidney disease, and we're talking about metabolism, they have to go through those organs. So if those organs are affected, you can see different variations in how your drugs are going to be metabolized. The dosing may need to be changed in those disease states. Nutrition, we talk about binding, so depending on what I'm eating, my metabolism because I don't eat or because I eat too much, my activity, physical activity, all of those things play a very big role. We talk about grapefruit juice when we talk about statins sometimes because those will affect CYP3A4. And so with that, you can see the levels of your medication be affected by if somebody drinks grapefruit juice. They gotta drink quite a bit, but and then also sometimes with like warfarin, we'll talk about different foods that will affect their warfarin levels. So there's lots of different things that can play into the metabolism of the drug, and it's not super, cut and dry. The age. So when we talk about kids, y'all will deal with peds when you get to your senior semester, but they're not just like little adults, right? Like their bodies work completely different. So some of our medications that we talk about, a kid can't take it, right? It'll say, oh, must be at least 12 years old, must be 18 years old. Don't use if they're less than 6 months old, okay? Like you have different age cutoffs. I'll point some of those out when we look at some of the drugs, but just understand that like their bodies are not a mirror image of ours in a smaller version, okay? They have different metabolism. When you're looking at elderly patients, you see that they end up having less muscle, less free water, and more fat, right? We're gonna get softer. I'm not gonna work out. But get softer when we get older, right? And so you'll see that that can change things. That can change my distribution. That can just change my binding, okay? All of the things that we just talked about. And then stuff just naturally starts to slow down. And when you look at like creatinine clearance and serum creatinine in your elderly patients, you're gonna see that sometimes it starts to go up, okay? They're not performing as well. Their serum creatinine will go up, their creatinine clearance will go down. They're not performing as well because they're older. Their body has been through some things at that point, right? So it's just a natural progression of things. So all of these things kind of come into play whenever you're looking at dosing your patients. This is just telling you about the Child-Pugh classification, okay? I don't need you to, again, remember any of this stuff up here. Just understand there's several different things that go into play. What I want you to understand is that A is the least severe and C is the most. Okay? So you have A, B, and C, and then what you would do is you would look up, depending on the drug, you would look up that drug monograph. You can go into LexiDrug, LexiComp, and you would say, all right, my person has a child Q score or they're in the class B. And then you would go on there and it would say, okay, for class B, you need to decrease the dose by 25%, bless you. Or it may say you need no dosage adjustment at all. So all I need you to remember from here is A, B, and C. A is the best. I mean, it's not good, but A is the best and C is the worst, okay? This is just an example. I don't need you to remember the example. This is just telling you, like, if I went and I looked up metronidazole, and my person they were class A or B, then I wouldn't need to do a dose adjustment. But if they were class C, it's telling me that I need to reduce their dose by 50%. Okay, so it's telling me what to do with the dose. You don't need to remember it. All right, we have 4 minutes. Keep going. All right, elimination. So we're looking at elimination. Again, this was us, like we did what we needed to do. We got our metabolites. They're gonna go into that glomerulus, and then you're gonna have some that could be reabsorbed or they could be eliminated. It depends on what our body is gonna do and if there's ion trapping or not, which is what would reabsorb them. So you also have drugs being eliminated through feces. You're gonna have drugs being eliminated through your lungs whenever you're breathing it, depending on what the drug is, and then also from people sweating, right? Because that's fluid that's coming from our body also, and your meds will sometimes be in that, okay? So understand several different routes in which we can eliminate medications, and that we can have some of that be reabsorbed or recirculated back into the body. This is just showing you, again, medications going in, medications coming out of a glomerulus. So when you're looking at the drug going in, the way that I think about it, it goes in through the afferent, so it's arriving. And then it exits out of the efferent or efferent, however you say, depends on how you say it. And that's exit, right? So those both start with E. So that's how I remember it. A, afferent arriving, E, efferent going out. And so it will go through this, and then you'll either see where the drug will get reabsorbed, so it'll be in this tubule, and the drug can either be reabsorbed back into the capillary network here, or it will stay in this tubule and be eliminated via our urine, if that is the route. Again, we have other routes as well, okay? But this is specifically talking about our urine. This is looking at several different ways that we're talking about clearance or clearing a drug. And this is essentially not just clearing a drug, but it can be clearance as far as like how your creatinine clearance, which is what we're going to specifically look at, because you're going to see a lot about creatinine clearance, and you're going to see a lot in your drug monographs on what is the cutoff of which I can use, what is the creatinine clearance cutoff in which I can use this drug. And we're going to see that moving forward on some of our medications. So I don't need you to remember this definition. I'm going to tell you what I need you to remember. Not definition, these equations. I don't want you to remember those. But you could potentially calculate elimination. I don't need you to calculate elimination because they have calculators online for that that are very good and they're very efficient. Okay, so that is for your information. Again, this is an equation. Don't need you to remember that equation. And then, big idea here, understand clearance is additive, right? So no matter where it's coming from, I add it all together, that is the amount of drug that is going to be cleared from my body. It's not just saying that it's renal, it could also be hepatic, right? It could also be what came out of my lungs, okay? So think about it as, it is the picture as a whole, not just one spot. We typically just think about urine and that's it. This isn't the case when we're talking about our clearance. So the elimination by all routes, any route that we can think of. Again, I don't need you to remember this calculation. Just understand that if blood flow is affected, your clearance can be affected, right? Because I'm not pushing things through as quickly. So if that slows down, my clearance may slow down. All right, so that's like, think about an elderly patient, right? If they're not doing this as much and it's kind of doing this, that drug is going to be hanging around a little bit longer, right? Because it's not doing this, it's going a lot slower, okay? All right, we'll stop here, and then we're gonna do our calculations because I want y'all to get that in, and then y'all will be free. So 10 minutes. 10:40.
Hey, how are you? Oh, good. So, I was curious, you know how some people when they get sick, they're like, I'm gonna go for a run, or I'm gonna go silent, like sweat it out, you know what I mean? Are they doing themselves any favors if they already took medication? You know what I mean? Because not to get it out there.
Right, so, no, they're not doing it something big, but it's not hurting. Also, like, I want to tell people, like, no, they don't know, oh, you're sick, no, it's not. But, it's not gonna be, there's like, as per the so, in theory, you are right. But it also says that one
I did.
so it's kind of like
It's like a break.
you want to try to look up see if it works? Hi, how are you? What's up? Yes.
How about I just do it?
I will be there. I don't have anything.
Yeah. I think we were all in the same group. Yeah, let me know for the volunteering. I said something beginning and I just left. Well, she does it
Oh, yeah. My daughter,
This one, I'm trying to get
Yeah. Maybe they have like a home.
I only found this one in Egypt. Like 2 years old and have a driver's license. That's why they use this one. Others, they have like background check.
I can't wait till last.
Are they scared of
So it depends what they have you do, because like when I used to work in animal rescue, I never did the actual in front, like getting the dogs. I ran actual like tests and stuff, so managing like feeding stuff. When they use these monsters for, because usually stuff like that, when you do the background check, a lot of times you can be the one, they're gonna have you like at like PetSmart or something, and you're trying to get people to dump it. So like your simple stuff.
Maybe I should call.
Yeah, like a simple stuff is really like, you know, you show up to the kennels and then you just clean it. There's not the whole clean. That's what they these people at the kennels like clean stuff. And then like you know, so one's like opening up the animals, so they can actually just like have you hang out with yeah, so that you typically use the background check for but like if you're yeah, so like it depends what your head is like. If you're looking to take a dog and like hang out for a day, yeah, a lot of times they'll want to switch you and take a dog. But like yeah, so like if you're gonna go help them actually clean the kennel and stuff and like take care of them, they can be honest.
Yeah, because at the end of the day, still gonna watch over them. Like, the risk is on that one.
And they're not gonna have you do
Gentlemen, you're I can make all these kids not well. This dragging like it's like kids been to school super late and just like I'm like literally trying to like struggle for like put this on. My first thought when I was like, I'm gonna start
Alright, everybody, we're gonna start. Switch to your calculation. I have a question for y'all, because I tried to view my kids in the student view. When y'all are downloading the lecture, is it cutting off the slides? Not all the time?
From the app.
Okay, I'm gonna try to later today. I keep doing it. I'm gonna try to see if I can download it as a PowerPoint and then save it as a PDF and then repost the other ones in a PDF version, so I'll stick it under the PowerPoint version, if that is happening. Because the words are on there if you open it in PowerPoint, so I don't know if you're not saving it as a PowerPoint or you're using a different program, if that's why it's like cutting off. So I'll try to do that today. Alright, so we're gonna do calculations. Martha is gonna help. Oh no. Hi Martha, thanks. What is wrong here? She is a 4th year pharmacy student, so she's about to be done being a pharmacist, which will be so exciting. So y'all be nice, okay? Especially when you're writing prescriptions, because this is what we have to deal with. We're gonna have nice PA pharmacist relationships. So we're gonna go over calculations. I'm gonna go and run and grab some paper because y'all don't have any in here. And that way I will, if you need some, when you see me walk back in, just raise your hand. If you have some, just get some out so that you know, like, going through the motions is how you learn calculations, to be honest with you, okay? I'll be right back. Yes, ma'am.
I had like one keys at my house, but it was probably like my last speaking position. So we had to get like.
Alright, everyone, let's get started. Can everyone hear me in the back? So here are your learning objectives for your reference for later. So first we have standard medication administration times. When you see Q 3 hours, the Q means every, 3 indicates how many hours there are. And so when we're looking at this on a 24-hour time frame, we'll do 24 divided by 3 hours to get how many times a day they'll be taking this medication. And so we'll continue that on all the way until 12 hours, 24 hours. When we see QID, we could think of this as a quarter in day, so 4 times a day. CID will be 3 times a day. BID will be twice a day, or like 5. Right. And then we have the conversion factors. So the most common one that you see and use is the 1 kilogram equals 2.2 pounds. And then the others are 1 inch equals 2.54 centimeters, 1 cc, which is a unit of liquid, equals 1 milliliter. A tablespoon is 5 milliliters. 1 tablespoon is 15. So you see teaspoon, 3 times that will equal the tablespoon. And then we have the basic metric system. So 1 kilogram equals 1,000 grams. 1 gram equals 1,000 milligrams. And then 1 milligram equals 1,000 micrograms. And then 1 liter equals 1,000 milliliters. Okay, so when you see milligrams per hour, it can be shown as a couple of different ways. So milligrams slash hour will equal milligrams per hour, which can also equal milligrams over 1 hour. So when you see this, they're all synonymous. In pharmaceutical calculations, the main point of this slide is that the parts of the percentage represent the grams of drug in 100 milliliters of solution. So
So for example, for a weight and volume expression, when you see 1% weight by volume, we are seeing that it's 1 gram of drug in 100 milliliters of solution. And so if we always assume that the specific gravity of the liquid will always equal 1 as if it were water. So you don't have to worry about any of that when you see any of the solution problems. And then, as I said before, so 1% weight per volume, 1% of 100 milliliters is taken to be 100 grams. So 1 gram in 100 milliliters. And so there are a couple of different ways we can have preparations. So we can have solutions, we can have lotions, and we can have like volume. So the drug is a liquid and a liquid. So for weight and volume, when you see W per V, that's weight and volume expressed as a percentage. So of the grams in 100 milliliters. When you see volume in volume, that's going to be milliliters in 100 milliliters of constituent or the liquid preparation. And then if we see weight and weight or W per W, that's going to be number of grams of a constituent in 100 grams of solution. So 3% of the weight per weight will be 3 grams over 100 grams. Are there any questions so far? Yes.
Sorry, for weight ratio, that's like comparable stuff, so like lotion springs.
Right. So for our first question, we have ratio and proportions. So most of the problems that we have can be solved this way. And for example, we have 1 grain equals 65 milligrams. So how could you answer the question, how many milligrams are in 5 grains of aspirin? And so we can use ratio and proportion. And so what do we know? So 1 grain contains 65 milligrams. That would be 1 grain over 65 milligrams. And then what do we want to know? So the question asks 5 grains of aspirin. So 5 grains contains X milligrams. We'll set this up to a proportion, setting them equal to each other. So 1 grain is over 65 milligrams, and it'll equal 5 grains over X milligrams. When you're doing this, you want to always make sure that if the grain is, whatever you're trying to find is on the same, the units are on the same area. So grain is on top. If you're putting it there, it will equal grain, which is also on top. So making sure the units are in the same places. And then we'll cross multiply. So the 65 milligrams times the 5 grains will equal the 1 grain. So haven't put it over yet, but it'll be 65 times 5 equals the 325 milligrams times grains over X. You multiply by X on both sides, divide by the 1 grain to cancel out the units, and you will be left with 325 milligrams. So let's do another example so we can figure this out. You prescribe an antibiotic, cephalexin, 250 milligrams Q6 hours for 10 days. How many milliliters of total volume of cephalexin oral suspension with a concentration of 250 milligrams per 5 milliliters should the patient receive? So we'll highlight the important parts that we should focus on. So 250 milligrams every 6 hours for 10 days. We're looking for milliliters, and we're trying to find out how many we need from the concentration of 250 milligrams per 5 milliliters. And so every 6 hours, 24 divided by 6, hours in the day will equal 4 times a day. And so 250 milligrams times 4 will equal 1,000 milligrams per day. We will set this up as a ratio. So the concentration, 250 milligrams over 5 milliliters, will equal 1,000 milligrams times over x. We'll cross multiply, and we will move the 5 milliliters over to multiply by the 1,000 to get the 5,000 over x. Multiply by x, divide by the 250, and we will get x equals 20 milliliters. But we aren't done yet because this is just 20 milliliters per day, and we want the total over the whole duration that we're going to be giving this medication to them. So you'll take the 20 milliliters, multiply it by the 10 days, and we will get the 200 milliliter total volume. Are there any questions so far? So you have a young child who's currently taking 1.2 milliliters of acetaminophen. It drops at a concentration of 100 milligrams per milliliter. You want to convert it to an equal dose using acetaminophen elixir that has a concentration of 160 over 5 milliliters. So how many milliliters of the elixir equals 1.2 milliliters of the drops? We will highlight the important things we should look at when we are looking at this problem. And so what we have is the 100 milliliters and the 100 milligrams per milliliter. And the child is taking 1.2 milliliters of drops. So we want to find how many milligrams they are taking for that. So we set it up as a ratio. 100 milligrams over 1 milliliter will equal the x over 1.2 milliliter. We'll solve for x, and we get 120 milligrams. Now that we have how much of the dose or this medication that we're giving them from the drops, we will take that and set up a ratio with the Tylenol elixir. And so we'll get the 160 milligrams over 5 equals 120 milligrams over x. So the concentration of the elixir equaling how much dose we're giving the child. We solve for x, and we will get 3.75 milliliters. And that's the answer. Are there any questions about this? So we want to start a 192.5 pound man on heparin, starting with 80 units per kilogram loading dose. The only heparin that's in stock is 10 milliliter vial with a concentration of 5,000 units per milliliter. How many milliliters will you need for the loading dose? And so if you look at this, we'll highlight the important parts. So we see that we're given pounds, and the heparin loading dose is 80 units per kilogram. So looking at this, we want to realize that we need to convert the pounds into kilograms. So 192.5 pounds divided by 2.2 kilograms will equal the 87.5 kilograms. So now using this, we can set up a proportion. So 80 units over kilograms will equal the x over 87.5 kilograms. And so using cross multiplication, we'll find that there is 7,000 units. And then we have in stock right now a 10 milliliter vial with concentration of 5,000 units per milliliter. And so using this, we'll set up a ratio. So 5,000 units per milliliter equals 7,000 units over x. When we solve for x, we will then get 1.4 milliliters. Are there any questions here? Am I going too fast? I need to slow down. So for this one, we have a 6-year-old child who weighs 66 pounds requires medication. The required dose of medication is 25 milligrams per kilogram per day, but dosed at every 8 hours. The concentration of the suspension is 150 milligrams per 5 milliliters. How many milliliters will the child take for each dose? So looking at this problem, can anyone tell me what the first calculation you would do? Yes. So we did a 66 divided by 2.2, and we will get 30 kilograms. And now that we have the 25 milligrams per kilogram per day, we'll do that proportion. So 25 times 30 will equal 750 milligrams a day. Now we see that it is dosed at every 8 hours, so we will dose it 3 times a day. So we will multiply it's dosed 3 times a day, so we'll take 750 divided by 3 will equal 250 milligrams per dose. Use it since we're finding each dose. And then 150 milligrams over 5 milliliters equals 250 milligrams over x. So putting that into a proportion, we solve for x, we will get the 1.3 milliliters each dose. Alright, so now we have mannitol. We want to use it for the reduction of intracranial pressure in a 154-pound man. The dose is 1.5 grams per kilogram, and you have 20% weight by volume mannitol solution. How many milliliters of the solution do you need? And so, does anyone remember what the units for weight per volume is? Yes, correct. And so, how about I give you about 5 minutes to try this problem out, and let me know how it goes. Tell me if you have any questions along the way. did y'all get?
Class 25.
725? Yes. Did y'all have any questions while you were doing it? And we will move on to the next question. So we have IV infusion on an 80 kilogram female at a rate of 0.1 units per kilogram per hour. An IV bag contains 50 units of insulin and 500 milliliters of normal saline. What rates in milliliters per hour do you run the infusion? Right, so first we will multiply the 80 kilograms by the 0.1 units to find how many units they should be receiving. So 0.1 times 80 equals 8 units per hour. Next, we will take the 50 units over 500, which is contained in normal saline, and equal that to how many milliliters she'll need. So 80 units per hour over X. And then when we solve for X, we will get 80 milliliters per hour. Does that make sense? Any questions? Right, next we have a 198-pound patient who has overdosed on acetaminophen. And so the loading dose of acetylcysteine, the antidote, is 140 milligrams per kilogram. And a maintenance dose is 70 milligrams per kilogram. We have a 20% weight by volume solution in stock. How many milliliters of acetylcysteine will you need for both the loading dose and the first maintenance dose? And then what is the total amount of antidote administered? So first we will find how many, we'll convert her into kilograms. So 198 divided by 2.2 will be 90. Secondly, we'll find how much of the loading dose, what the strength is, how many milligrams of that we need, and that will be 12,600 milligrams. After that, we'll do the same with the maintenance dose to find how many milligrams we need from that dose. Okay. We will take the 12,600 milligrams and equal to 12.6 grams because the 20% weight by volume is in grams. So we need to make sure that we take milligrams, put it in grams so we can make it into the ratio and the units will match. We'll also do the same thing for the maintenance dose. And so 1 gram equals 1,000 milligrams. You'll be dividing by 1,000 for both of them to reach grams. That's how that calculation worked out. We'll then take the 20 grams over 100 milliliters, which was the 20% weight by volume. You'll make a proportion of the loading dose, so that's 12.6 grams over X. We'll solve for X. You'll get 73 milliliters for the loading dose.
Sorry, how did you know you need to go from milligrams to grams?
So we have the 20% weight by volume, and we know what are the units for that.
1 gram.
Yes. So when we set up the proportion and we see like the units aren't matching, we want to make a note that we have to make them match. And so that's very important as well. Thank you. That's a great question. Thank you for bringing that up. So always write your units down. Make sure you're matching them. Are there any other questions? Now we'll do the same thing for the maintenance dose. So we have the stock percentage of 20 grams over 100 milliliters. We'll set that equal to the 6.3 grams over X. And when we solve, we'll get 31.5 milliliter maintenance. So we found the loading dose, we found the maintenance dose, and then there was a third part of this question for the total amount. So we'll take the 63 milliliters plus the 31.5, and that will equal 94.25, giving us the total. So now we have a recommended dose of beclomethasone, which is an aerosolized inhalant of 168 micrograms administered twice a day. The commercial inhaler delivers 62 micrograms per metered inhalation and contains 200 inhalations. How many inhalers should the patient receive if a 60-day supply is prescribed? So first we want to determine the total dose needed for a 60-day supply. So in the problem, we see that we have 168 micrograms administered twice daily. So this means they're getting 168 times 2. So we'll do the 168 micrograms times 2 to get the total daily dose, which will equal 336 micrograms per day. And then over 60 days, so we'll multiply that by 60, and we see that they need a 20,160 microgram total dose for the entire 60 days. After that, we will set up the ratio. So each inhaler sprays 42 micrograms per 1 inhalation. We'll equal that to the 20,160 micrograms to find out how many inhalations they need. When we solve for X, we will get 480 inhalations. In the problem, it states that one inhaler has 200 inhalations. We'll set that up in a proportion to where they need 480 inhalations, so we'll solve for how many inhalers they'll need to reach that. We see that they need 2.4 inhalers, but since you can't take out any liquid or split up an inhaler, we're going to always round up with inhalers so that they get everything that they need. So the answer here is 3. Any questions? Next we have IV ampicillin. It's indicated in a 2-year-old female with an upper respiratory infection of bacterial origin. The recommended dose is 100 milligrams per kilogram per day in 4 divided doses. She's 33 pounds. The ampicillin you have is 30 milligrams per milliliter. Calculate the amount of ampicillin that you will give in a single dose. So I'm going to give you about 5 minutes to do this problem. so with the key point of this problem is remembering to look at what they want, so like per dose versus what you're given. So you're given milligrams per kilogram per day, 4 divided doses, making sure you split that up into the doses and not what you need per day. Now, we have a dose in milliliters for albuterol, so 0.5% weight per volume nebulizer solution. The child you're treating weighs 66 pounds, and you want to use a 0.15 milligrams per kilogram per dose. And so how many milliliters of the 0.5% weight per volume albuterol solution do you need per dose? Would you all like to take another 5 minutes to do it? Okay. for this, answer. Okay, so we have pounds to begin with, we convert them into kilograms, and then we want to find how much of the dose that she wants, so the 4.5 milligrams per dose. Then we need to convert the, so we set up the proportion, we realize that, oh, it's in milligrams, so we want to make sure that the units match each other again. So from milligrams into grams, you're going to divide by the 1,000 to convert it into the grams. And then we'll put that into the proportion, so the 0.5% equals the grams over 100 milliliters, and set that equal to the 0.0045 grams over x. And then when we solve for that, we'll get the 0.9 milliliters. Are there any other questions for this problem? Are there any questions in general? Alrighty, well that's the end of my PowerPoint presentation.
Real quick, when we're talking about calculation, and I know y'all kind of saw it when you're going through, the more that you do it, the better. And there's a worksheet on there. It doesn't go through it step by step like this, but it has the answer. So if you're doing the worksheet, you get stuck, y'all try to figure it out. You can't. I'm in my office most of the time if I'm not next door. If I'm not there, then just text me and I'll tell you like, yeah, I'm coming back or I'm not. So that worksheet is really good to try to like get the repetitiveness in for it. And then also, remembering, like, read the question, because that's what makes people miss the calculation problems. They forget what they're solving for, okay? So look at your units, that's typically what happens, and then people just start guessing, or they feel like, well, it's just a couple of questions on the exam, like, I don't care, and I'm gonna throw it. Don't be that PA, because dosing and knowing how to calculate matters. Yes, pharmacy is there, right, and we catch stuff, but we can also mess up something too. So y'all are the first line, and then we come behind to say like, all right, but we'll also be like, hey, you see that PA who's always messing up on calculations? That would make you blush. You're gonna dose kids. You have to know how to do this, right? If a kid comes into your office, you need to know what you're doing, okay? So please don't just blow it off, like for exam purposes, feel like we have lots of comments. I didn't come to PA school to do math. I got it. I understand. But you're gonna do math because you're giving people meds, right? So please just take a minute to like let it soak into your brain. There's always more than one way to do stuff. I have learned unique things from different classes that have come through on how they solve problems. As long as you get the right answer, I don't care. I just want you to get the right answer, okay? So this is one way. Dimensional analysis, another way. Some people are very inclined in math and they look at the problem and they already know what they pulled out and they're like, here's the answer. And I'm looking like, cool, that's a neat party trick, okay? Because I have to write it all down. So make sure that you understand it because you're going to need it for your career, not just for farm, not just for the test, all right? I'm good with y'all for today, so whatever else you need, we're done.